Good morning and welcome to our session. We're going to be discussing the new normal in healthcare delivery and financing after COVID. I'm joined this morning by Adam Barde from Blue Shield of California and Dr. Tanya Dansky of MemorialCare Health Systems. And we hope that you will enjoy this presentation because you'll really have some broad perspective here. You have the perspective of a health plan, you'll have the perspective of a provider, and you'll have a perspective from myself, being a consultant for 3M in this industry. So I'm gonna set the stage. This is a little introduction to myself, just to say that I've been in this industry for 40 years, and what's happened during COVID was pretty much unprecedented in my time in this industry. And in fact, 2020 was a new low for the healthcare industry. Now, COVID amplified some deep-rooted problems in several major areas. And the first is the overcapacity that we built for low-value services. And when I talk about this, I'm really referring to services such as ED visits. So what happened when people stopped going to the emergency department, it was a huge contributor to a decline in hospital margins. Now, some of these visits were critical visits, and it resulted in loss of life in a care delivery crisis. But many that we've been tracking were preventable visits in that these are visits that could have been treated in an alternative setting, such as primary care. And the impact that these loss of visits had on the margin really indicated that we have over time in the US system of care overinvested in the capacity to treat low value visits. On the contrary, COVID highlighted the fact that there was inadequate investment in crisis management. When you think about what happened with lack of space, a lack of staff, a lack of protective equipment, and the industry tried to rebound and set up field hospitals, and that all took a very long time. Well, this just indicates that we really need to invest more in flexible treatment areas. So take our bricks and mortar and change what's inside of it so that we can more adequately address the next public health issue. And finally, I just want to say that COVID really amplified the poor investment in primary care. Reimbursement for primary care is not aligned with the impact that these teams have on outcomes. A few years back, we asked our 3M client medical directors how much of the premium dollar did they think primary care actually controlled. And there was a lot of debate, but they landed on between 60 and 70% of the healthcare dollar under the strong influence of primary care. But yet at that time, and I don't think it's improved at all, those same people reported that they were only paying between 4 and 6% of the premium dollar on primary care. So the result in that low investment has really yielded a shortage and a crisis in the primary care delivery system. Now, from an overall perspective, COVID really changed the dynamic that we have seen between our payer clients and their provider communities. We've been working on new payment models, new delivery models, and if you think about initiatives in value-based care, that was sent into a tailspin. We've been trying to project per capita expectations based upon a period of time that was COVID, where there was a great deal of expensive care for a small amount of members, while the majority of the members went without care at all. And we've been trying to base quality measures on that same period of time, where you had a lot of chronic follow-up care and preventive care going by the wayside. So it's really been a challenge to determine what to do about value-based programs in 2021. And we expect that impact to continue into 2022. So we've also been assisting our clients in developing alternative models for delivery and financing to address the current need, and also to, and more importantly, to be better equipped to adapt to the next crisis. Okay. All right, so the data I'm showing on the screen now is from a sampling of our clients. And really what it's showing is the difference in cases, the percent of cases, 2019 versus 2020 for inpatient admits and outpatient visits. And again, these are the numbers of cases and the percent change. But when you look at these percent differences, the impact, the dollar impact is really much higher, especially when you look into some of the categories on the inpatient side, such as specialty surgery, and on the outpatient side, nuclear medicine, which are high dollar services. So the drop in hospital margins, or I should say with the drop in hospital margins, came to knock on the door of our payers to be creative with reimbursement in the moment. And this was really to avoid having what should have been a short-term crisis turn into a longer-term challenge, as some of their hospitals were truly just trying to keep the doors open. And from a public health perspective, you'll see that there's been a drop in the mental health services and a drop in preventative care. You're not really seeing it on the outpatient visit side because it's disguised in the medical category. But when you think about the loss of preventive care and the loss of chronic follow-up during this period of time, you can pretty much imagine that the effects of this are likely not to be felt until well into the future. Okay, we've also been working on developing new models of care delivery with our payers. And COVID forced this adoption of new models, the most prevalent of which was telehealth. No surprise that in 2019, telehealth represented 2% of primary care visits, but in 2020, we saw that number go up to 35%. Now, prior to the pandemic, I would say there was a general reluctance to use or recognize this type of care delivery. But now it's not if our payers use it, but it's really a question of how to use it effectively. And many questions remain. You can see them on the screen there, but I'd point out a couple that we've been wrestling with is, do you limit telehealth to local physician groups who have built that capability? Or do you expand the acceptance and the reimbursement to the national vendors? Do you allow this for primary care versus emergent care? There's a lot of literature out there that is already starting to suggest that when you allow telehealth for primary care, that a lot of the ancillary services that go along with that are not being completed. But when you think about the rural areas, and we work with payers in many rural areas, this might be the new model for the future, given the shortage in primary care providers. So we're also looking at the effectiveness of telediagnosis. And, as I pointed out with the primary care ancillary follow-ups, the data are just coming in on this now. So more for this analysis in the future. Okay, and finally, another key to managing a pandemic or even just overall population health was and still is lacking in this country, and that is a national repository for public health information across the entire population. So when we realized this omission during COVID, we jumped into action and we started helping our clients using our own risk adjustment methodology, clinical risk groups, to start to stratify their populations. And we started with age and the high-risk COVID diagnoses. But then when we got to our clients with Medicaid populations, as you can well imagine, that over 80% of those populations had one of those high-risk diagnoses. So then we started tagging multiple comorbidities and looking for a stratification based on that third pillar. And moving into the future to address future public health crises, we're now able to layer in social determinants of health and understand how that impacts the treatment and the allocation of resources. Finally, over on the right, there's a great example of what happened in Spain, where the Ministry of Health, one of our clients, was able to use this methodology to actually distribute PPE during the initial phases of the COVID crisis, and then later, I imagine they'll be using that for vaccine distribution. So that's a great use of public health data and stratification methodology. So with that, now I'm going to turn it over to Adam. Just a quick reminder that there is a Q&A screen open. Please put your questions in there as we go along, and we will be reviewing them at the end. So, Adam?
All right, thank you, Carole. Well, it's wonderful to be here and to join my esteemed panelists in this great discussion about how COVID has changed the industry from all of our different perspectives. I'm just watching the audio to make sure that it's going well. In addition to the Q&A, I also believe that a poll will be automatically sent in a few minutes, and then another one about 15 minutes later. So we'd love to hear and see your responses, and then we can chat about the results, which we'll pull up when they come through. So my name's Adam Barde, as Carole said. Like Carole, I've been in healthcare my entire career. For the most part, I've been on the provider side of the industry, both in long-term care for the early part of my career, and then moved into the rest of medicine and healthcare after that. And I've now been at Blue Shield for just over 3 years on our now what we call our health transformation team as a senior director. Next slide, please, Carole. So I'm going to speak a little bit about why health transformation is critical, and I'll connect that to how we are accelerating that effort because of COVID. This demonstrates here that up until the 1950s, our healthcare system was very focused on the sick and the absence of acute disease. And the 2.0 model, though we intended it to be much more of a coordinated healthcare system, the focus was still very much on the absence of disease, of illness. Our goal, and we're not there yet, our goal is to create this community integrated health system whereby healthcare is optimized through close collaboration. We use the word omni-channel sometimes, where healthcare can be attained through multiple venues, bringing care both to our homes, both virtually, but also to our homes, meaning areas or places that we might spend time, whether it be at a pharmacy, a grocery store, or a clinic in a neighborhood. And again, we're not there yet, but we believe that we are making progress along with our partners across the healthcare spectrum. And that's the 3.0 model, if you will. Next slide, please, Carole. So in order to do that, we focused on the triple aim, of course, which most everybody should be familiar with. And the triple aim, as everyone should know, is improving health in general for the population. The second pillar is enhancing patient care and their experience. And then, of course, reducing the cost of healthcare itself. But we've taken this triple aim and we've sort of internally expanded it into the quintuple aim. And those two additions are improving the provider experience which I'll talk about in a second. And that includes everything from changing the reimbursement model, changing how we as an insurer, as a payer, interact with our provider partners in providing healthcare for our members and the community. And then the fifth is increasing health equity. We know that, as Carole mentioned, that many populations and individuals are directly adversely impacted by some of the social determinants of health, whether it be access to transportation to get to healthcare, whether it be access to healthy food because of living in food deserts, whether it be access to finding the right provider because they live in an area where there may not be enough primary care physicians, where there may not be enough specialists. And we are focusing on all of these because we believe, again, this coordinated or collaborative approach needs to think about each of these pillars. Next slide, please, Carole. So the colorful Venn diagram was our initial attempt a few years ago at creating what we initially called the healthcare model of the future. And it was looking at these three pillars, which continue to the right. We didn't eliminate them, but it was a focus on holistic health, which is mostly defined by how we address and help to mitigate the adverse effect, as I mentioned, of social determinants of health. And then this overlapping combination of personal care and high-tech, high-touch support. So it's using technology, it's using individuals such as community health advocates, using tools such as shared decision-making that we did provide to our provider partners to help them improve their practice of medicine, support their practice of medicine, and also reimburse them for their work as they deserve to be reimbursed. The model has sort of shifted into this sort of, I don't know if it's a daisy or flower shape, but it really delivers the same message. If you focus on the center for a second, in this next year, and very much because of COVID, we are focusing our work this year on these three middle efforts. Pharmacy care reimagined, we call it, behavioral health reimagined, and health at home. And those will be enabled by some specific solutions, such as I mentioned, the community health advocates, shared decision-making, our payment models, which I'll speak about more in a second, and real-time claim settlement so providers can get paid promptly. And then it will be powered with technology using advanced analytics, a personal health record that we would develop that our members and patients can use to have their longitudinal medical record with them and able to share with their providers. And then a holistic health platform, which is another tool that we've developed to improve the overall care and ability for data to be shared across platforms with providers. So how will we do that? I'll talk about the first one in a second, which we call Primary Care Reimagined, which was a program that was rapidly accelerated because of COVID, through much closer development of relationships with strategic provider partners, and through consumer partnerships, which I would also include looking for vendors and companies who've developed technology that we can integrate into existing systems, both on our end and at the providers. We don't want to create the swivel chair problem where providers need to log into 3 different systems and look at them individually. We're trying to figure out how to put it together with the advanced analytics and data so they can see the whole picture of a patient or a population to make decisions on the best care for their patients. Next slide, please. So how are we doing that? So one of the ways, and this is not necessarily new, but certainly we believe this is a very important part of the journey, is our pay-for-value payment model strategy. And so we will, and we've already started, and I'll speak about it again in a second, the Primary Care Reimagined model is a great example, but we will reimburse and reward for value versus volume. We know that providers are burnt out. We know that the current modeling almost requires unsustainable productivity in order to get reimbursed what providers deserve to be reimbursed. And so we're switching that to value with a focus on other metrics, such as quality outcomes and more. And I'm just going to pause on that for a second because I have one more slide that'll dig into that a little bit more. We will engage in member feedback to understand how they value the healthcare delivery experience and what suggestions they might have to improving their own accessibility for healthcare. We want to reward quality outcomes and their efforts to breaking down these barriers of health equity and allowing everybody who needs healthcare to obtain it. And I won't read every bullet on here in the interest of time, but the reason why we will do this is to have increased focus, for example, on the member experience. So we understand as a payer what's working and what's not working, and to focus on meaningful measures, not measures that don't help us align and partner with our providers just for the sake of reporting. And one of my favorites, being that I came from the provider side of the industry and seeing providers such as, not that I saw Dr. Dansky in a clinic necessarily, but as a good example of the sort of loss of this joy of practicing medicine because too much time was spent on administrative requirements and less on being directly with their patients and their families and their caregivers. And so we want to support that. So we'll do that by implementing multiple payment models, even outside of primary care. We have some specialty care models, some bundled payment models, some we're still testing, some we've accelerated and we're sort of testing at scale, and some we're already in the process of developing sort of a go-to-market strategy to release to a broader population. And as I said, incentives will be tied to the member experience, to outcomes, and the evaluation criteria will be inclusive of that equity and social determinants of health based on available data. All right, last slide, please, Carole. So as I said, one of the programs that we accelerated because of COVID is it's not the title of the slide, but it's called Primary Care Reimagined. And this program was directed directly to a select large group of primary care providers in our network, because the intent was first to test and make sure that it worked, and then make modifications, sort of using the design thinking model. And by the way, I apologize for some background noise. And so the Primary Care Reimagined payment model is built with 4 components. There's a per member per month. From a provider's perspective, it would be per Blue Shield covered patient per month, which are monthly advanced payments for the majority of the codes that would be used in a standard primary care practice, which is adjusted based on service intensity and benefits. So it's not just necessarily a flat fee. It is used, we use a measurement and attribution model to understand and adjust the PMPM accordingly. And then there's the payment for the pay for value services and the performance outcomes, which are part of this monthly advance payment to support traditional or new approaches, right? Part of what we want to do is support new and innovative approaches to care delivery, but not necessarily us telling providers what to do, but working with them to learn what works best. And then for some of the codes, and there's quite a long list of some of the services that are not part of the PMPM, there's the same fee-for-service agreement is in place, and so those are reimbursable. And then lastly, the performance incentives, which are tied to the HEDIS metrics, resource utilization measures, as I mentioned before, the member satisfaction scores. And so all of that is sort of reconciled biannually and then reimbursed promptly based on that performance. So it's pretty exciting work at Blue Shield that we're able to accelerate this work, and that Blue Shield has spent a great deal of time and effort in trying to reimagine healthcare and really make a difference both in the lives of our providers and our members patients and communities. And so with that, I wonder, Carole, before I hand it off, if we should look at one of the polls first. Tanya, in the interest of time, why don't I hand it off to you? So let me hand it off to Dr. Dansky, and then while you're continuing, Carole, you and I can pull up maybe the first poll, and then we can bring that up towards the end after some Q&A. All right, Tanya.
Thank you so much, Adam. I am so pleased to be able to join. I had a little Wi-Fi problem, so I wasn't here for the initial intros, but I'm Tanya Dansky. I am a pediatrician, a pediatric hospitalist, and hospice and palliative medicine doctor by training. But I've been in healthcare physician leadership roles, both on the plan and provider side for a few years now. So I am the Senior Medical Director with MemorialCare Medical Group, and I'm going to kind of be that cleanup hitter with the baseball analogy and kind of bring together that high-level data-driven information that Carole shared, as well as the health plan vision and, real-time pilots that they've got going on with the experience from a provider group that has been carrying on and still is during the pandemic and is looking strategically to the future. So MemorialCare is a group that's based in Orange County, as well as the Long Beach area from as far north as Torrance, all the way down to San Juan Capistrano. I'm going to talk about virtual health as an example of how healthcare has changed significantly during the pandemic, and share with you a few of the exciting things that we've recently launched and are looking forward to, as we know the pandemic isn't going anywhere anytime soon. So next slide. This is not supposed to be an eye chart. I'm not an eye doctor, but it's to give you a sense that the MemorialCare team had approximately 18 to 24 month roadmap to go from kind of 0 to 100 in terms of their virtual health program. This was all set prior to the pandemic. They knew they wanted to go forward with virtual health, but rather than a 18 to 24 month timeline, it got compressed into approximately a 1 to 2 week period. And they went live with their integrated video visits to begin with within that first 7 to 10 days after the announcement of the pandemic. So next slide. On the communication in healthcare, we know is key. Trying to explain how virtual health fits in with brick and mortar and traditional ways of accessing healthcare, we know is a work in progress. On our website at this point, as we've been adding more and more virtual tools, we've put it all together under something that we've listed as MemorialCare Now. And so whether someone needs a virtual visit or an e-visit or urgent care or in-person emergency care, they can kind of access it all in one place and get directly to information or directly actually to the links to start a visit if that's what they need. Next slide. I guess I can do my own slides. So one of the things that Carole mentioned, which was perfect segue, is, there's still data that we know needs to be looked at in terms of the effectiveness of telediagnosis. I decided not to go too in depth in terms of virtual visits because many systems have, gone live and are using video enabled visits. Which we have been. We've got them fully integrated into both our Epic platform as well as MemorialCare patients can access them directly through our website. They don't need to be on Epic or have a MyChart account to have a visit. So that part is kind of, I'm just taking that for granted that we've got that all up and running. We have both primary care visits. We have a video urgent care on demand platform. And what we've just launched literally in this last week is something that's very exciting. And so this is called TitoCare. And this is, how do we enhance our video visits to improve both the diagnostic capability, the physician satisfaction, getting back to Adam's, quadruple, quintuple aim. Because, for a physician or an advanced health practitioner, NPPA, they want some hands-on or some better data than just what can be done on the video screen. And you can get a lot done through a video visit, but how can we take it to the next level? And so what TytoCare does is we have this little kit that we can get into the patient's hands, and I won't go into all the detail, but basically you have the capability of an otoscope. You can look in their ear. You have a stethoscope. You can listen to their heart and lungs, record a heart tracing. There's a tongue depressor, so you can see into the back of their throat. And it's the main TytoCare piece. These little attachments go on there. It's voice enabled. It walks you through it. And you can also take photos or look directly at, say, a skin lesion or a rash. You can use the oxygen saturation monitor to check someone's blood levels of oxygen. And then you can also do a blood pressure cuff. And so we are excited to launch this and really looking at the various use cases for this to be able to enhance our video visits. And this is just another picture showing you, this one's called the Tyto at Home. There's another one that you can put in, say, a workplace or maybe even in a clinic to have a virtual capability, almost like a kiosk type of setting. But what we started with is the at home. And just out of interest, the use cases that we are starting with are a couple different ones, are really complicated, high risk at home members where we already have an in-home nurse practitioner program where they go out and that really is their primary care provider. Back to Blue Shield's model where they're saying, health at home for the patients that do have limited mobility or transportation, we bring their care to them in the home. But as there's, limited efficiency to that. You have to drive across town and go see someone. So we're working with a new type of health role we've created called our health ambassadors. And these folks are able to go out into the home and help the patient get connected to the technology. That way the nurse practitioner could access them, like do a visit enabled with TytoCare, but the nurse practitioner isn't always in their home. So that's one of the use cases that we're launching. We're also sharing this with some of our young families. And I'll show you later, we have a kind of a pregnancy app with remote monitoring. And so for some of the families that have had a baby and used our pregnancy app, we're connecting them now to TytoCare so that as their child grows, we can help them with some of those urgent pediatric type visits that often are disruptive. And especially with kids, you really want to look in their throat and look in their ears. So we're going to be able to use that as another one of our use cases, kind of different ends of the healthcare complexity spectrum. We also have had up and running for quite some time now these asynchronous evisits. You may hear this with other venues or other places called like a bot-based visit or AI-based visits. And so for very low acuity conditions such as urinary tract infections, lots and lots of kind of rule out COVID, URI type of symptoms, this is available 24 hours. The patient can go into the platform and answer a series of questions. If they had a rash, they can take a photo on their cell phone and upload it. It goes through the bot, through the AI, and gets to like a proposed diagnosis and treatment plan, including prescribing medications where applicable, but then they always have to be signed off by a provider. So there's a human healthcare provider at the end of it, and they can change the plan or say, you know what, this this really needs to be seen either with a video visit, it can be transitioned to, or an in-person visit. And we've had really great adoption of this by our patients. 2 a.m. urinary tract symptoms, don't even need to, wait till the morning or miss a day at work. We also have brought technology into the hands of our primary care doctors to try to help them with their job satisfaction and efficiency during the pandemic. It's sometimes hard to get the patients to come in even to primary care, let alone get them to go to a specialist office. And so we're working with Arista MD. We've been in pilot mode for almost a year, and we've now gone live for our full network of all of our primary care doctors and AHPs. And we are doing e-specialty consults. So just to share a little bit of the data so far, the way this works, the primary care doctor, rather than asking for a referral for our HMO patients to go see a specialist, they're able to just within their same EMR, click and ask for an e-specialty consult. Our most popular, again, is dermatology. They can take a photo, they can upload it straight into the electronic medical record, which gets transmitted to the dermatologist for a diagnosis within 24 hours. And it's pretty small. And I didn't mean for everyone to read all of the figures to the right, but it basically gives you the breadth of this is just a portion of the specialists where we're able to get e-consults. Almost 90% of the time, that specialist e-consult can replace in-person visit. It's not always, nor should it be, but it can impact the care plan 91% of the time. So even if someone is going to need to go see the specialist in person, there may be suggestions or workup that could be started before the patient gets to the specialist. Our primary care doctors for this first year have been very happy with this. Doctors, if anyone's worked with them, are not always easy to please. So we've got a 4.9 out of 5 star rating for how the PCPs feel about these specialist consults. So we're really happy with that. We are using this for our HMO patients and some of our direct to employer ACO patients. And our next steps, if there's any plans in the audience, are that we would really like to offer this to all of our patients, including PPO. And so we're taking a plan by plan approach and looking for innovation, open-minded plans that are ready to embrace this, because we've already got it up and running and our doctors have already adopted. This was the pregnancy app I was talking about. And so it's not just education, it's actually, we can do remote blood pressure monitoring. And then there's live, again, this is all a hybrid between that high tech, high touch, or technology and people, because although it's all in the app, there's actually a call center and monitoring to make sure that if any blood pressure readings are elevated within these certain ranges, then the providers and the patients are notified right away. Again, 24 hours. And the results of this go directly into Epic, into our providers' EMR, so they can see how often it's used and what the blood pressures are, what the trends are. So they've been very happy with this. We have multiple OBGYNs and nurse midwives and nurse practitioners that do our pregnancy care. And so we've built this in to kind of automatically prescribe it basically to any of our new pregnant patients. Anyone who knows me from the past would know that I can't give a presentation without talking about behavioral health. But we have a cognitive behavioral therapy based online behavioral health partner called Silver Cloud. And again, they were actually started in the UK, and they've been clinically driven for over 20 years. Most of the programs are self-guided, but there's coaches as well. So again, it's that same story of the combination or hybrid approach between technology and providers and support. We've had great results with this. Again, and we had huge increases in utilization as the pandemic has progressed. So we've been able to have this tool available for anyone who, again, didn't feel comfortable talking with their provider about mental health. They can access it themselves, or their doctor or provider can prescribe it for them directly through the patient portal. We've also launched, again, not that unique, but just to tell the full story, we have a symptom checker and a chat bot. They can book appointments, find a provider. And then we also, again, especially at the height of the pandemic, but still going strong, is we have a texting tool called Twistle. And when we do have a patient who has tested positive in our system, we're able to have regular checks and we give them a thermometer and an oxygen saturation monitor. And so there's ongoing regular monitoring and communication for them while they're at home for the 14 days after their positive test. And then we have 24-hour nurse telephone advice nurses who monitor the patient responses and reach out if someone's not responding or entering their data. So this is just a little summary of, our results so far. We've had over 10,000 same-day virtual urgent care visits. I already mentioned the almost 90% avoidance of specialty visits. Over half of our e-visits, those AI visits, were done after hours, so potentially saving, significant emergency room visits or just patient worry and suffering, after hours. Some systems have reported a real decrease in their video visit engagement. Of course, it's not, 100% or 50% like it was at one point. But we're still at about 12% of all of our visits are being done virtually. I talked about the new role, these virtual health ambassadors that can help bridge that technology gap for patients. And we've had symptom checks. We've monitored over 300 pregnancies. And about 65% of our Silver Cloud patients have actually seen significant improvement in their moderate to severe depression or anxiety. So that is my last slide. I know that was a lot. I tried to talk really fast because we just had so many different examples of our assignment here. How has healthcare been, reshaped during the pandemic? And if anyone, has any questions that weren't already put in the chat, please feel free to do so. And I think Carole is going to bring us home here.
Yes, so we have the results of 2 polls, but I think I'd like to get to the Q&A first and then revisit the polls because there's lots of good questions in here. And the first one, I'd like to start with Tanya, and then Adam, if you have anything to add on. It's with respect to telehealth and broadband limitations. The question is there any data or analyses on the use of telehealth in low-income communities or rural communities? And Tanya, since we're going to you first, I would tag on to that as in regard to low-income communities. You talked about a lot of technology, and do you think that low-income communities are disadvantaged by some of the technology that you've been trying to implement?
Yeah, so I think that's part of our strategy with the ambassadors, for example, is they're both bilingual. We're hoping to expand our multicultural, multilingual approach to this because, again, in our Orange County community, of course, there are Spanish speakers, but we have a very high Mandarin and Vietnamese speaking community as well. So we want to always, have our staff mirror our communities. So that's one piece. Some of this we're at the whim of technology companies. So again, shout out to think about our multicultural, multilingual world that we live in. Most of our materials are available right now in English and Spanish. And, we're continuing to encourage our partners to offer these in other languages as well. In terms of broadband, I've worked on other telehealth projects in California, especially, and up in the Pacific Northwest. And broadband access, I think, definitely is a health equity issue. I was just reading something about that this morning. There's, renewed interest in federal funding to try to get the broadband companies to actually do what they were supposed to do in the past, which was to connect, the whole country. So it is inequitable, and it's unjust, and it's one of many in a long list of things that we need to work for to ensure health equity. So definitely don't take that for granted. And it's, I personally do not have the solution today, but I know there's a lot of smart people working on this.
Adam,
I'll just piggyback and give Tanya a thumbs up for all of those comments. That's where the timing couldn't be any worse for this background noise. I really apologize. Both as you called the ambassadors and we call the CHA's community health advocates, are exactly one of the solutions or initiatives that we put in place, because in many cases they are bilingual and they have had some additional training. And for the communities where broadband or even cell phone access might be limited, or people may have plans that don't provide enough access, we are able to reach out to them in more traditional human, either face-to-face. Of course, with COVID, that's made that more difficult. So then it's been a lot more telephonically. And then I was also going to add, I've read recently that when we think about the social determinants of health, something that's often overlooked is what the same person asked is broadband, right? Internet access should be one of the categories of social determinants of health, because that kind of access could prohibit or limit these virtual visits. It could prohibit or limit the ability of the Tidal Care technology to transmit the data back to the provider and their EMR. Or it could limit even just researching on reputable web pages about medical conditions, and to help our members and patients in the communities know where to go with more questions.
Thank you, Adam. And I'm just going to finish this question by saying that in our data, which is still very limited, so I don't want to draw any conclusions, but we're seeing an impact more on low income rather than rural. Which might suggest that it's the cost of the bandwidth and not necessarily a geographic issue. But there are databases that measure and track the availability and the quality of broadband. And we are looking into adding that actually to our SDOH platform as a potential determinant. So next question, Tanya, I think we'll go to you first, because this is really talking about provider staff. During the last administration, immigration restrictions and pandemic restrictions reduced the supply of immigrant providers and support staff. Do you see this rebounding? Do you have any experience with this in your organization, Tanya?
Yeah, I mean, as the senior medical director, I'm involved in all of our recruiting. And although we are in a, geographically desirable area of Orange County and Long Beach, I know, this is like a problem upon a problem. We have a physician shortage in general. We have, some resistance to expanding that provider workforce with maybe the less innovative thinking providers out there in terms of scope of practice of AHPs, of PAs and nurse practitioners, although things are definitely changing, but that can help us, especially with our primary care workforce. I actually was asking a question in a previous session. I think workforce in general right now is just such a hot topic, unfortunately, with the combination of the comment from Patrick, which is completely true and relevant, as well as the pipeline issues and with current COVID requirements, COVID vaccine requirements, our already short workforce is unfortunately going to go down even further due to healthcare providers and staff that are not willing to get vaccinated and will not be able to work in California healthcare anymore. And then in addition, there's just, we have so many open positions. I just shout out, if anyone knows anyone who's got a young person who's trying to decide what career to go into, I mean, healthcare, there are so many open positions, and even considering agencies, temp agencies, expensive consulting firms, whoever we can find, there's zero applicants. And we have open physician positions, open NP, PA, midwife positions, medical assistants, front office, nurses, everyone you can think of. There's a plethora of open positions with really zero applicants right now. So it's a big problem.
Adam, through the lens of a health plan, are you seeing any effects or feeling any effects from this?
We definitely see the same impact on our communities. I mean, the short answer to the question, do we see this rebounding or not? My personal answer, and I know the answer of Blue Shield is we certainly hope so. It's just not acceptable what occurred in these last few years. I don't want to get too deep because I'm not connected enough with some of our efforts, but I know that this is a priority for Blue Shield as well, for us to improve the supply of immigrant providers as well, so we can help support the provider community at large and support both, especially BIPOC providers in our BIPOC communities as well.
Okay, thank you. Looks like we have one last question. And Adam, it's for you. How are you getting those members to complete their satisfaction scores?
Great question, and I think it's an ongoing challenge for us. In many cases, well, the satisfaction surveys come from the provider. We've asked for some transparency into seeing that information, or working with the provider to co-market or co-brand the survey itself. And that was one of our ahas, is that many patients, and everybody on this call is a patient, and we might feel the same way, that we wouldn't necessarily want to complete a satisfaction survey from our payer, but we might if it was from the provider or possibly co-branded. So we're looking at all of those different ways of getting the survey out, both digital, both as soon and as quickly after the appointment as possible. All of that we hope will improve engagement with those surveys. But as with many surveys, reporting is low, and we are trying to figure out what's the best, efficient, and most appropriate way of incentivizing members to complete those satisfaction surveys.
Tanya, did you have anything you wanted to add?
Yeah, I mean, I guess the only thing I would add, just, someone who's looked at patient satisfaction surveys from the, sort of system perspective, the IPA perspective, how IHA looks at it, CMS, everyone's looking at these surveys, but, it kind of falls on the patient to do this pretty tedious, very detailed, many, many questions, some of them kind of hard to interpret. It is the gold standard. It's what we all look at. We have great, benchmarking data to work towards. And our organization as a whole does perform very well. We put a lot of effort into this, a lot of training, especially with new providers or providers who have certain areas that are problematic in their scores. We really drill down to that detailed level often about communication. But we also have a kind of, I call it the quick and dirty. We do send out a text, one question, kind of would you recommend type of survey. It's called Repugen. And we're able to get a lot more responses. Granted, they're short, and it's, a 1 to 10 score. But we've actually integrated into our clinical workflow so that if anyone does give a lower score, our practice manager, clinical operations folks will reach out directly to that patient within less than 24 hours to really figure out what's going on, do that service recovery, make those, care connections if needed, and respond to it right away. Because I think that's one of the pieces that's missing in terms of a patient satisfaction surveys, often based on encounter data or claims data, and it comes out months and months after the visit. And so how do we get that more real-time information? And how do we catch any trends early? If we have a particular provider whose scores have been great and they start to go down, that gives our physician leadership a chance to check in with that doctor and see what's going on with them, and look at it from kind of a physician wellness perspective as well.
Carole, if I can jump in, Tanya said something that reminded me that I don't think this is necessarily the intent of this question in particular, but I think it's important to we've been talking a lot about providers and certainly what we can do from the reimbursement side of the industry or of the equation. But we also do our own net promoter score, which is a single question, like Tanya said, which asks, how likely are you to recommend Blue Shield of California to your friends and family. And so we use, again, industry thresholds and lots of data to understand what the net promoter scores that we receive mean, and putting together both rapid response teams or tiger teams to address some of the issues that we know our members face to improve the experience for them as well from the payer perspective. So we're very interested in understanding both and doing what we can to improve healthcare across the spectrum.
Okay, thank you, Adam. Well, we're reaching the top of the hour, but very quickly before we send you off to your next session, we'll review the results of the polls. And the first question, I'm not sure you can see these on your screen, but the first question was, if COVID becomes an endemic disease in the U.S., will the healthcare system need to permanently change? And the overwhelming response at 75% was yes, probably for all the reasons we were discussing today. The next one is very interesting. It said, have current value-based care initiatives in California yielded satisfactory results? 0 people answered yes. 38% said somewhat, and 56 were unsure. So more work to be done in California on this, I guess. With that, I'd like to, on behalf of Tanya and Adam, I'll let them say their goodbyes as well. Thank you for joining the session, and enjoy the rest of the conference.
Thank you for being our moderator, Carole.
I'll just echo that. Yes, thank you, Carole.
You're most welcome.